Hello, everyone, and welcome to UroNurse. We meet every Saturday at 9 a.m. Central Daylight Time. If you're watching us on YouTube, great. Be sure to visit our website at uronurse.com to learn more about us, to see past episodes, and also to see how you can join us in the Zoom so that you can ask questions too. We are going to start off with a half-hour show. We got a great show for you today. Half-hour general questions is our usual format. Our second half hour, we're taking a deep dive, and we have a new panelist with us, Todd Thompson, who was nice enough to donate his time to do this. He's going to talk to you about those stubborn catheter problems, how to get to unclog the catheter. Todd was recommended by one of you attendees out there who said he had heard Todd speak and said, definitely get this guy on the show. So that's why you're here, Todd. Also, we're going to take questions and answers, so please feel free to put anything in on the Q&A box. We'll start off with that. I added a new thing to the website that I would like you to take a look at. UroNurse.com now has a calendar. If you look at the calendar page, you can look ahead and see what things have booked up. One of the great things that came out of this meeting is I was able to talk to a lot of the experts from SUNA. And I will tell you, they all seem to know about us. So that's a good thing. And many of them were asking, hey, when can I help out? And when can I do a presentation? So I booked some of that talent. I've got more talent coming on board. We've got a lot of fun things to look forward to. Just a sneak peek. Next week, we are going to go into our second part of the erectile dysfunction talk. So be sure to join us for more information on erectile dysfunction. And at this point, I'm going to let the panelists introduce themselves. Let me just remove my spotlight. And anybody that I'm Vic Sinise. If you don't know who I am, I'm the host of the show. And I'm going to start out by letting Todd tell us a little bit about himself. Todd, go ahead.
Good morning. My name is Todd. I'm a nurse in Tucson, Arizona. I work for the Veterans Department, and I focus on complex medical patients in the home. I work with home-based primary care, and so I primarily deal with long-term urinary catheterization of homebound veterans.
Great, and glad to have you join us today. Lori, again, for those that don't know who you are, be sure to unmute yourself and let us know who you are.
I've been here from the get-go. My name is Lori Atkinson. I've been in urology for 24 years. I'm certified in urology, and I work for Northwestern at Delnor in Geneva, Illinois.
Great. And then last but not least, John Lynn, let us know a little bit about you.
Pleasure to be here. Thank you for having me again. I've actually been lurking in the background since the first episode of UroNurse. I've been very interested in it, and I'm looking forward to bringing value to everyone today. I'm a solo practice urologist in Gilbert, Arizona, and I look forward to just bringing some information and sharing what I know.
All right, that's great. All right, so be sure to start putting any questions that you have for the first half hour, or we'll just run through till we run out of questions. I did have a comment from Rebecca. She loves the catheter circle. Hey, that's in our logo. Believe it or not, and I'm not a designer, but I designed all the stuff that you see showing up as far as logos, etc. And hey, someday, who knows, maybe we'll have merch. So with that circle. I actually ordered, I haven't gotten them yet, but I did order some shirts with the logo on them so I can wear an official UroNurse shirt. So look forward to maybe some merch. All righty. If we don't have a question, I've got some follow-up stuff that I was thinking about. So I went to the meeting, and of course I attended some erectile dysfunction talks, and a few things that I think I left out of my first part, which for those that weren't there, was about the medications. I've got a few statements here. So one thing I forgot to mention is finasteride. Patients come in complaining, hey, I'm having erectile dysfunction. Look at their medications. We mentioned that, but I don't think I had mentioned, but a 7 to 8% risk from the use of finasteride. Anybody else see any of that with their use for ED? John, any thoughts?
Well, I think, the thing is, a lot of these guys, when do people usually get on finasteride? It's usually when they're older with an enlarged prostate, right? So a lot of them already have underlying cardiovascular disease, and they already have some form of erectile dysfunction. Can the ED be worsened with finasteride? Of course it can. But in my situation here where I've seen these patients, they come in a little bit older, they already have pre-existing ED, so it makes no difference to them. They already had ED. But whenever I start a patient on finasteride, I always consent them. Like I have a consent statement in my EHR to number one, remind me to talk about it. And number two, I actually talk to the patients about all the potential things that could happen. Like breast enlargement, you can't donate blood. Post-finasteride syndrome, meaning permanent erectile dysfunction. So these are just some of the things that I cover with whenever I prescribe a 5-alpha reductase inhibitor.
Yeah. I think that's a good point. That's why I thought it'd be nice to circle around and bring that back up. Here's another one that I forgot to mention. And it actually was a little different than what I had originally thought about. So the retinitis pigmentosa, I know back originally when it came out, that was a contraindication to the use of the PDE5 inhibitors. Now it's actually contraindicated, but can be used, or not contraindicated, but can be used with caution. So a little change from the original. And I guess the rationale for that is the retinitis pigmentosa is a PDE6 issue. They have a lower number of that. And the early PDE5, such as the Viagra, although it blocks PDE5, it blocks other things, including PDE6. So that was the reason for that. But I was surprised to hear that. I forgot to mention, I was thinking to myself, I should have mentioned retinitis. And then I'm like, oh, wait a second. Now it's actually not actually contraindicated. It can be used with caution, probably using it with the more newer drugs. Lori, have you had any thoughts on that? Or
I actually had no idea about that, to be quite honest with you. Had no idea, new information.
Good. Again, folks, if you have any questions or concerns or comments, feel free to put those in the Q&A. I'd like to welcome all of our attendees. We got somebody on the phone. That's great. Claire, Diane, Emily, Katie, Leo, Melanie, Neil, Rebecca, Rhonda, Robert, and Susie all joining us today. I see a lot of names that I've seen before, so we're looking forward to a great meeting. Let's see.
Doc, I got a question for you. With the finasteride, is the erectile dysfunction goes away if they stop the finasteride? You'd have people that would prefer to do that, or it can be permanent?
It's permanent. That post-finasteride syndrome is permanent erectile dysfunction.
And that's for anybody. They don't have people that discontinue it and get their...
Of course you do. Of course you do have patients who can regain erectile dysfunction, but post-finasteride syndrome is permanent erectile dysfunction. I always give that little caveat whenever I prescribe a 5-ARI, even though it's easy to prescribe just like another medication. Most patients don't have any of these side effects, but still.
And what's the incidence of that?
You know what? It's pretty low.
Oh.
Yeah.
I do have a question from Leo. And the question is post-ED syndrome, I think referring to what we were just talking about, is dutasteride versus finasteride any difference? John, do you know any?
I treat both because they're both in the same class, 5-ARIs. I treat them both. If I prescribe dutasteride, Jalin, finasteride, I always give that same caution.
And, yeah. I would assume the hair product also has the same issue.
Although at a lower dose, I'm not sure how that, just like, do I see a drastic reduction in PSA when someone's been on low dose finasteride? I haven't seen that. So I don't know if you can translate that low dose used to that high dose, higher dose, 5 milligrams.
Whether it's a dose related, yeah.
Yeah, I'm not sure if it is.
Still, it's got to be frustrating to have all that great hair and not be able to get an erection.
Yes. All righty. Since I don't have a question, I have another one that I forgot to mention. So PDE5 inhibitors work better on an empty stomach, especially with Viagra. So the that was always something I caution patients. Best have everybody wants to go out and have a nice dinner and then sex afterwards, but the dinner can slow down the effect of the Viagra. Now, I think some of the newer ones are less dependent or less requirement of having a empty stomach. Any thoughts from the audience or from the panelist?
Wasn't it fat that was the problem, not empty stomach? It was primarily, so a low-fat diet was
Low fat.
okay. So
Yeah.
go out and have a salad with your date.
Fatty
don't
meals.
drink.
Yeah, fatty meals. And we talked about that during your presentation on ED, oral medication for ED. Yeah. Alcohol, just like Shakespeare said, alcohol induces the desire, but takes away from the performance.
Yeah, absolutely. Emily sent a question in. For patients who are on a GI tube, is there any other alternative medication for ProScar? Don't know that it can't be crushed and put through a GI tube, though.
Yeah, you should be able to. It's a pill.
Yeah.
Not a capsule.
So I don't think there's an issue. Hopefully that answered your question, Emily. And that's the last thing I had from my couple of thoughts while I was sitting through the lecture on ED. If we don't have any other questions coming in, I'm always glad to move along to the actual meat of the subject and have Todd take over. So here's your chance, folks. Any questions, feel free to put them through. Otherwise, we're going to go to our second half.
And to ask questions, you see that little icon on your device or if you're on a desktop, that Q&A button, just click on that and type your question and we will field them.
And Emily did follow up with, I have a pharmacist recommending to DC ProScar for a GI tube, for G tube. I can't think of why that would be.
Yeah, ProScar or finasteride is it's a pill.
Yeah,
so
it's getting into the stomach. So I just don't.
Yeah, it's a pill. So I don't understand.
It's not an extended release. Or...
No. So I would guess, Emily, it would be a good idea to see if the pharmacist can explain their rationale. They may have something that we don't know about, different training, but it doesn't make sense anyway. But good question. Thanks. Appreciate the question. Todd, you ready to let us know?
Sure, I'm more than happy to. Let me go ahead and share my screen. I hope everyone, if you're watching on their phone, you might not be able to see it, unfortunately. So again, my focus and my specialty is on long-term urinary catheterization. And when I started working with this population, I ran into a lot of difficulties in dealing with people that were clogging, complications, different things like that. And I would run to different doctors and I would ask them different things. And how do I deal with this? How do I deal with that? And I got a lot of conflicting information. And one would tell me to flush, another one would tell me to flush with something different. Another one of my chief urologists would just complain about how he hates long-term urinary catheters and just walk away from me and never give me an answer. So I decided to just see if I could do some research and kind of work on figuring this out. So one of the first things to remember is that when a person has a long-term urinary catheter, we're fundamentally changing the way that the urinary system works. And so all of the anatomy and all of the physiology kind of goes out the window, and we got to kind of rethink how we look at how the urinary system operates. So the normal function of the bladder is to fill and to flush and fill and to flush. And this has a protective mechanism of preventing urinary tract infections, urinary stones, different things like that. And when we put in a catheter, we're not allowing that system to happen. And we're actually creating a little bit of a swamp in the bottom of the bladder of about 20 to 50 cc's of urine, sometimes more, sometimes less. The other thing is that the catheter itself is an inert object that allows biofilm to grow on it. The lining of the bladder should protect against biofilm, doesn't allow it to adhere. And when you put a catheter in there, then it's a perfect environment. And the catheter itself can irritate the lining of the bladder. It can cause irritation, cystitis, mechanical injury. And another thing I didn't quite think about was that the catheter itself prevents the prostate seminal vesicles from draining. And so my recommendation, I'm just going to say it now, is that when you have someone that has a long-term urinary catheter, you should actually leave the catheter out for about an hour. in between catheter changes to allow those seminal vesicles to drain. So what I do is I now pull the catheter when I first see the patient, and then right before I leave, I put it in to allow the urinary system to kind of relax a little bit. So let me show you a case study of one of the patients that I work with. I had a 90-year-old with a 16 French hydrogel suprapubic catheter. He was actually flushing with 20 to 30 cc's of vinegar twice a day, and he was still clogging about every 12 to 16 days. His outpatient provider was giving him antibiotics pretty regularly because he felt like he had a UTI, and he was going to the ED pretty often for clogged catheters, despite the home health nurse changing it about every 2 weeks. And this is actually a picture of the catheter when I removed it from him. You know, one of the main things to think about is whenever you're dealing with any complication with a catheter is to stop using the catheter. And often catheters are placed for inappropriate reasons. Patients have conditions that change. They no longer require a catheter. And when you're dealing with long-term urinary catheterization, you'll get these patients that'll come to you and they have the catheter, and they'll talk and say, hey, you know, we're having this problem with the catheter. And I'll ask the doc, why do they have it? And sometimes they would just tell me, I don't know. They came to me with it. And so we need to challenge, do they actually need a catheter? And think about, can we do intermittent catheters, external catheters, incontinence management supplies? So always challenge, does this patient need a urinary catheter? I've had situations where they were placed for wound care needs or post-urinary retention from being in the hospital, and then the catheter just never got pulled, and they've had it for years. So whenever I deal with a patient that has a chronic urinary catheter and I'm trying to figure out why they're clogging, I always kind of do a chart review, see what kind of care they're doing. I like to interview the patient caregivers about their catheter care. I kind of like a UA culture and sensitivity, and I'm not exactly wanting to treat with an antibiotic, but I actually like to know what the actual bacteria is, because there's different strategies dealing with different bacteria. And I also like to know the glucose, protein, pH, those type of things, which helps me come up with a strategy. The problem with urinary, getting a culture and sensitivity is that you have a lot of docs that just want to treat whenever you get that culture and sensitivity. And so you need to be able to prove that you're not going to treat, put a addendum on it or something saying that this is just confirmatory, not for treatment. And the last thing that I do is that I like to cut open the catheter and check for incrustation on the inside and the outside. A catheter is not a black box. We can cut it open and we can actually see what's happening here. And this is a picture of me actually kind of cutting it open. I used to actually remove the catheter and sneak it outside. And this is actually a picture of my car. And I would cut it open and examine it and take pictures of it kind of in secret. But now I actually do it at bedside because I find that the patients actually learn a lot. And it's a teaching tool because you can say, this is what's happening in the catheter, and we're going to try these interventions, and then we're going to look at it in a period of time, and we're going to compare the old picture to the new picture and kind of see how it's done. So I actually do it at bedside now. And I use a catheter dissection kit that I put together. Basically, it's just some pair of serrated scissors. They work best, and some forceps and some tweezers. And, a simple way to check it is just to cut it diagonally through it a couple times to see how clogged it is. And if you really want to examine it, you can cut it lengthwise and get a better example. Definitely don't be a wimp when you do this, okay? And you learn a lot. You learn a whole lot, and it gives you a good technique in order to use to know where they are and what your interventions do. Okay, and don't be a wimp. If you don't want to do it, maybe you could train an MSA or someone to do it. So what do I see when I open up a catheter? Basically, what I see is biofilm, right? And biofilm is one of the most powerful or difficult things to deal with in urinary catheterization. It is a very what am I trying to say? It's a very protective mechanism, because what you're doing is you're having bacteria adhere and it forms a microcolony, and this microcolony can be multiple different bacterias that work together to gain nutrients and to get rid of, to protect itself with like a slime layer. Antibiotics don't penetrate it, and it can be incredibly protective. Okay, so you can see kind of the process of the biofilm formation right here. So here are actually good examples of biofilm on a catheter. The one that I showed earlier that I cut open on the hood of my car was a 59-year-old with ALS, had a chronic indwelling catheter with multiple hospitalizations. You can kind of see the little chunks of slimy biofilm on it. Nurses used to tell me that what was clogging was the islets, but when I actually started opening it up, it's more common to clog right below the balloon, like 2 or 3, about a centimeter into the catheter or right below the balloon, and not the islets, because the islets are actually getting washed with urine all the time. We also have a 74-year-old with a suprapubic catheter that was clogging about every 3 weeks with biofilm leaking around the catheter, and this one is a real slimy one. So the other thing that when I open them up is that I'll see incrustation by urease producing bacteria. And urease producing bacteria like Proteus mirabilis actually results in the conversion of urine into ammonia. And so if you look at this chart, you can see where the Proteus mirabilis or something of that sort will break down the urea and create the ammonia. The ammonia causes the alkaline to rise up to about a pH of about 8 or 9, and it'll actually cause the natural calcium, magnesium in the urine to precipitate out and form incrustation. And that's where the crystal formation comes. A lot of people will say, what is the sediment in the bag? And often that is just this process happening where it doesn't form the crystals, it just forms the sediment, but it's basically the same process where you see that white powder or sediment inside the bag. So this is actually for the geeks out there, this is kind of the chemical process of the breakdown of urea into carbon dioxide and water and ammonia, rising that pH. And this is the Proteus mirabilis having food. When you look at how powerful things like Proteus mirabilis and Proteus vulgaris is compared to E. coli, it actually has 39 times more ability to break down urea. And so it's actually a pretty powerful bacteria to do that. So here's a couple examples of incrustation by urease producing bacteria. I just call them crusty catheters. So we had our 90-year-old male with a 16 French hydrogel suprapubic catheter. He was flushing with acetic acid, clogging every 10 to 14 days. And then I think I pulled this one after about a week and a half or so. The one on the right is an 87-year-old with a suprapubic catheter. This is actually a 22 French hydrogel. He was also flushing with acetic acid twice a day, and it was clogging after about every 7 to 10 days. I think I removed this one on day 5, just to kind of, it was when I was able to go out there and evaluate. You don't really want to let them clog if you can help it. And you can see that this one's probably about 50% clogged. And you can actually see that the clogging is worse right underneath the islets, not at the islets. One of the other great things that I love about cutting open a catheter is that sometimes I'll go out to someone's home or deal with a patient, and I'll cut open the catheter and there won't be any blockage in it. And so this actually rapidly allows me to move to my differential diagnoses and to identify other causes that will be because they're not actually clogging. The biggest one that I deal with is constipation. And so you'll have a bedbound patient or someone who is kind of mobility impaired and they're pretty impacted, and they'll complain of their urinary catheter not draining, and you remove the catheter, it looks great, I'll cut it open, I don't see anything, and so I can instantly just kind of roll them over and disimpact them and solve the problem that way. And that may have taken me a little bit longer to figure it out if I hadn't dissected the catheter. So one of the things you can do to improve catheter size is to think about different type of catheters. Each time you go up a size of a catheter, you're actually increasing the size of the catheter by about 20%. Okay. And I wanted to kind of understand what different kind of catheters do. And what I was able to do is find this study. It's actually from 1997, but let's be honest, catheters haven't changed that much since 1997. So I actually think it's a pretty good study. And what we see here is like the barred hydrogel coated latex in a laboratory situation. These were 14 French catheters that they were trying to clog in a perfect laboratory situation, actually lasted about 24 hours. And you can compare that to a silicone, which is number 2, the arrow is pointing in the wrong direction, which actually lasted about twice as long. And one of the things that's interesting is you can actually, they had a couple silver impregnated catheters in this study. And if you look at the barred hydrogel compared to the barred hydrogel silver coated, you can actually see that it lasted less time, and the silicone silver coated lasted less time than the all silicone. And it was kind of confusing to me why a silver impregnated catheter, an antimicrobial catheter, would actually last less than the same catheter that was not antimicrobial, because that kind of seemed odd to me. But when I started doing a little research, what I realized is that the silver coated catheters, the antimicrobial catheters, are actually extremely good at preventing clogging. And I mean, preventing bacteria to adhere to it. What it does is it kills the bacteria that adheres to it. And then that dead layer of bacterial cells allow other bacteria to attach to it. So the initial group of bacteria will attach to the catheter and die because it's an antimicrobial catheter. And then the extra bacteria will just attach to that bacteria. So it will actually clog a little bit quicker. So when I deal with urinary catheters, bigger catheters do clog slower. Each time you go up a size, you go up 20% on the internal diameter. Silicone catheters are actually better because they have a larger internal lumen. A 16 French hydrogel has a smaller lumen compared to a silicone. And if you don't believe me, just cut them open and look. The silicone is actually 45% larger. So a 16 silicone is actually the equivalent of a 12 latex. It's like going up 2 sizes just by switching to a silicone. Okay. Or so if you put a 16 silicone in, it's the equivalent to a 18-20 French latex. All right. The problems with going up to a larger size is it causes bladder spasms, bladder neck erosions, and can actually be a little uncomfortable. So one of the things I dealt with was flushing, and you'll often see recommendations on flushing with antiseptic solutions, acidic solutions, neutral solutions. And it kind of made sense to me because if it's clogged, you flush it, right? And in acute settings, they actually will flush catheters based on blood clots or status post-surgery or different things like that. But in long-term urinary catheters, it just doesn't make as much sense. The antiseptic solutions, if you're not able to kill biofilm with an antibiotic, why do you think you would be able to kill it with an antiseptic solution? And you're just maybe killing a little floaters, but you're not penetrating the biofilm. Acidic solutions, the idea is to decrease that incrustation, but you're irritating the lining of the bladder, and the acidic solution really isn't powerful enough to really break down that incrustation. And neutral solutions don't, it's just like a mechanical pushing something through it. Okay. So I was able to find a pretty good study that I liked on flushing, and this one was a head-to-head study comparing an acidic solution, normal saline, and an antimicrobial solution with new catheters over time. And what you can actually see is that all 3 of them increased the bacterial loads over time. None of them were effective at decreasing the bacterial loads. And what you would see is that after flushing you're killing some of the floaters, so the bacterial counts would go down for a couple hours, and then they would kind of quickly return to normal. And generally, catheter maintenance solutions can damage urothelium through chemical irritation, further causing blockage because you're irritating the lining of the bladder. Antimicrobial solutions doesn't appear to prevent or delay clogging, and it can actually develop resistant organisms. And I was never able to find a study where flushing in chronic urinary catheters improve the situation. And even with things like Stubby G and catheter maintenance solutions, when you think about it, what are they comparing these to in a clinical study? They're comparing them to normal saline, and normal saline's bad, right? They never compare them to doing nothing. And I thought that was kind of interesting. So what about the idea of acidification? When you're dealing with incrustation, then alkaline, what happens is that the urine pH will rise, causing the precipitation. So what about just trying to prevent it from becoming alkalinic, right? So this is like adding vitamin C or trying to keep the urine acidified and prevent that from happening. What I actually found was that the more you try to acidify the urine, the more you're giving fuel to the fire of the bacteria, and you're causing more ammonia conversion. And again, biofilm is such a powerful thing that it is resistant to acidic environments. You're not going to kill it by trying to acidify it. And what I noticed was that people would be put on something like vitamin C, but they weren't checking the pH before they put them on vitamin C and then checking it afterwards. And when I started doing that, I noticed that there was no change in their pH because of the ability of the urease producing bacteria to break down the urine. It was pretty good at just preventing acidification. Increasing fluids is actually a pretty good idea, and it's something that I would try to work on. The problem with increasing fluids is that it can be pretty difficult, especially with people that are elderly or with chronic urinary catheters. So the idea is that the increased flow rate will make it more difficult for biofilm to develop and keep the incrustation down, and that does work. But the problems with fluid intake is that it requires constant fluid intake, and that can be really difficult to maintain over time. So I would actually kind of bake it into their care by every time you take a pill, you got to drink this much water. And, it wasn't because of the pills, it was me just trying to get more water into them, and you can have problems with too much fluid, hyponatremia. They can have CHF, can be contraindicated for a lot of reasons. And so it's a kind of a difficult thing to do, but if you can, it's good to go with it. So this is actually my big thing that I learned about, which was preventing incrustation by using a chelating agent. Okay, and a chelating agent retards spontaneous nucleation. So what we're doing is we're taking a substance, we're attaching it to the calcium magnesium and preventing the calcium magnesium from forming incrustations. Chelating agents are used in a lot of different areas in medicine, like if someone has lead toxicity, they can get a chelating agent to attach to lead and allow the lead to leave the body without attaching to other things. This is basically the same philosophy. So what we're actually doing is, instead of trying to prevent the ammonia conversion, instead of preventing the urine from becoming alkaline, what we're doing is allowing it to become alkaline and giving it something to prevent it from precipitating. And the best thing that we can use is citrate. And citrate is a common thing found in the diet. You can also give it as a pill with potassium citrate. And this is actually a list of different things that have citrate in it. And my favorite is actually lemon juice. I don't like to use grapefruit juice because it's contraindicated. I don't like orange juice because it often has calcium in it. So what I like to use is lemon juice. So when I'm dealing with that incrustation, what I do is I try to increase fluids and to give them some citrate in the form of lemon juice. And so I'll take a shot glass and some reconstituted lemon juice, and I'll tell them to take 2 or 3 shot glasses in a liter of water and drink it throughout the day. It's called homemade lemonade or lemon water. And then I will titrate to effect, by cutting open the catheter and trying different techniques. I can watch how effective it is, and we can kind of basically dial it in. And so what I do is, when I'm dealing with a slimy catheter, I have other kind of interactions. But when I'm dealing with a crusty catheter, that incrustation, what I'm trying to do is to increase fluids a little bit and to add citrate and titrate it to effect. So I've kind of developed my own catheter blockage algorithm, and I'm happy to email this to anybody who wants it. And this is my technique that I use when I'm dealing with incrustation. So the first question obviously is the catheter necessary? Remove it. Then I like to inspect the urethral or stoma, look for any type of irritation. I'm not talking about it in this thing, but another one of my issues is that there's a lot of latex sensitivity that can happen because a lot of the supply is geared towards latex. The number one catheters are latex, and I've seen a lot of people with stomal irritations or urethral irritations. I put in a silicone and it goes away. And I don't think nurses often think about this because when you pull your supply, it's all latex catheters. So if I see anything that makes me think of latex sensitivity or red irritated stomas or urethras, I try to switch them to a silicone. So then I pull the catheter and I will dissect it and take a look at it. If I have a incrustation catheter, then what I'm trying to do is to add the citrate and the fluids and try to prevent that incrustation. If I just have a slimy catheter, which is, E. coli or something else, I'm basically, why are they having so much of a biofilm in their bladder? And often it's other causes, high glucose in their urine, prostatitis or something else that is the causative factor. And so I'm looking for underlying causative factors. And then I'm obviously always trying to improve their catheter care. I'll try to increase size, change the type from a latex to a silicone, increase fluids, those type of things, just try to basically improve it. And so every time I'm doing a change, I'm just trying to get it a little bit better and a little bit better to the point where the catheter is lasting as long as I need to. And as a last resort, there's some medications, methalamine or something like that I can recommend, or I may consult a urologist as a last resort, and kind of go from there. So what kind of results have I had? We talked about the 90-year-old with a 16 French hydrogel flushing. We stopped flushing, which, believe it or not, can be pretty traumatic for some people because they get pretty nervous when you tell them to stop flushing. And I would actually have patients that would flush behind my back or something like that. But I've never had a problem with stopping flushing. Changed to a silicone, it added the citrate, and you can kind of see the results. And this gentleman is changing every 6 weeks. So this catheter is 6 weeks old. You can see a little bit of sediment in there, but it's a pretty clear catheter. Patient, 87-year-old with a suprapubic, 22 French hydrogel. I switched him to a silicone also. Increased fluids throughout the A, added the lemon juice citrate, and we stopped flushing. And this one looks wonderful. You could eat off of this catheter. It looks so good. So we had the 74-year-old with a suprapubic clogging every 3 weeks with biofilm. He had a lot of biofilm all over that catheter. And I have a wrong slide. So the leaking around the catheter was actually caused by irritation. It was actually resolved by decreasing a catheter size. He didn't tolerate a silicone too well. He did better with a latex silicone. And really the key to improving the catheter function was to get the glucose out of his urine. And once we improved his diabetes management, the clogging went away. And then we had a 59-year-old with ALS, chronic indwelling catheter, multiple UTIs requiring hospitalizations. Why does a ALS patient need an indwelling catheter? He was just incontinent. We got rid of the indwelling catheter, switched him to external catheters, and he never had a UTI again. So this was just my abbreviated quick presentation, focusing mainly on incrustations. And I just kind of wanted to open it up from here.
Well, I just have to say that was a great treatment of a seemingly simple concept, but that's a great job, Todd.
Yeah, I honestly feel like patients with long-term urinary catheters sometimes to be like forgotten patients. The urologists are no offense, doc, but they're kind of done with them. they kind of ran out of interventions, and they're just kind of this person that is just having a long-term urinary catheter, and they don't get a lot of attention. And so, it's important to just not give up on it and to just keep working on it and working on it and working on it.
And one of the things that you said in the presentation was really important. And whenever I see a patient come into my office with a catheter, I always ask, why did you need that catheter? So the need, and often it's because they're in a skilled nursing facility or something like that. And the patient or the family would tell me, well, that's because it's easier for them because he was incontinent. So it's easier for the care staff. Well, you shouldn't have a catheter in a patient because it's convenient for the care staff.
Yep, it's the best way to deal with incrustation is to get rid of the catheter.
Yeah, so I always look for ways to get rid of the catheter, and cutting it open was a great idea too. I've never done that before.
Yeah, no, I call it reading the tea leaves, and and the problem is when you're not doing something like that, and you're trying to assess your interventions, what are you using to assess your intervention? But if you're cutting it open, you can actually take a picture of it, and then, okay, we're going to add some citrate, we're going to add some fluids, we're going to, stop flushing. And then the next time you're there, you can, hold up your phone and say, this is the picture of, last time we changed it, and this is what it looks like now. Good job. Right.
Yeah. And it surprised me that, go ahead.
I think that's huge. I'm definitely one of these. It's a visual learner, and getting the patient to buy into the whole process is half the trick. And I think that's an excellent suggestion, cutting the catheter open to show them, hey, here's your problem, because the patients hate it as much as we do, having to come into the office. They never clog at the start of the day. They clog at the end of the shift. It's always the same scenario. They're coming in, they're uncomfortable. So I think that's a great idea.
It surprised me that the silver impregnated catheters kind of ranked in the middle relative to clogging. And silicone, you said bar silicone worked the best, or one of the best.
Yeah. So, this is mainly due to the construction of a catheter. And what happens is when you look at the inside of a catheter, let me see if I can pull up a cross section while we're talking here about it. But it's completely different construction. So the latex catheter. I'm sorry, they only gave me 20 minutes to talk, so I cut out a lot of my favorite slides.
Well, maybe I can.
But the internal diameter of a silicone catheter is 45% larger. Yeah, there you go. So, so that's the latex catheter, and you can see that you've got a small hole, which is the fill, and then you have the urinary flow, and so there was actually a picture off to the right, which was a silicone catheter that was a little bit
So the big thing is the outside is what the measurement of the French is, but
That's
the
correct.
inside diameter is larger on a silicon. There's less bulk
Right.
needed. Yeah.
And so just switching to a silicone will allow it to last about 40% longer. Okay. And also, I think that silicone latex is actually a big problem in the urology department, that people aren't thinking about latex sensitivities. If you look at like a G-tube or any of those type of things, they've completely eliminated latex from a lot of those products because of the problems with latex sensitivities. And but in urology, we just keep using these latex catheters. And I have had patients that have a suprapubic catheter with granulated tissue, hyperplasia tissue all over it, and they're burning it off every month. And I switch them to a silicone catheter, and it pretty much goes away. And no one was thinking about the fact that they were having a latex allergy or latex sensitivity causing that hyperplasic tissue for years. And they're putting them through that difficult procedure, put in a 100% silicone, and they never had to get the burn it off again.
So I guess
Katie,
the question with the silicone catheters, and I'm going to bring this out, they're more uncomfortable for patients. If they're harder to pull, especially suprapubic tubes. When you use a silicone and you pull them out, it's not as easy as a latex. So I just wanted to ask you about that.
Well, so what you're talking about is that a silicone catheter will cuff. And the cuffing is because the silicone catheter is not as elastic as a latex catheter. And so the balloon's inflated for a period of time. And when you deflate it, it can form ridges or speed bumps, essentially. And this is an easy thing from a nursing perspective to kind of deal with. And that is that I leave the syringe attached. And when I'm dealing with a little bit of cuffing, what I'll do is I'll just bump like a half a cc of fluid back into the balloon to break that cuff and allow it to come out. But if you think about the discomfort of a patient dealing with a latex problem or dealing with incrustation over the period of them having the catheter, or a slight problem with the nurse pulling it out and a slight discomfort because they're dealing with cuffing, I really think it's better to deal with the catheter cuffing for that one brief moment than for the length of the time that the catheter's in and the discomfort it causes for the patient. And you're right, the silicone is a little bit more uncomfortable, right? And so there's a couple things that I can do. First off, you can decrease the size on a silicone, right? Because of that larger internal lumen, which will actually improve the comfort. Okay. The other thing I like to do is start people off with silicone with suprapubic so they don't know any better, essentially. Okay. That, you know, and if you can keep the silicone in for a little while, they'll get used to it. You know, I hate to put it that way, but it's just in comparison to a latex, it's not quite as comfortable. But you know, having a catheter, indwelling catheter is not comfortable. Having incrustation and chronic clogging is not comfortable. I've also, you know, will sometimes try to use a coude with a suprapubic because the curve will sometimes keep it from banging so much into the wall of the bladder as a way to kind of help with discomfort.
Do you, I don't know if you talked about this, but do you ever change the catheters more frequently because of clogging? I mean, I used to have patients that would come in every 2 weeks as opposed to 4 or 6.
So the strategy that I use is to measure the time that the catheter is clogging. So I'll take a couple of the times, and then I will try to change it a little bit earlier than that. Okay. But the great thing about cutting it open is you can see how clogged it is. And so what you can do is use that as a guide and say, look, this catheter is looking better. Let's go to 3 weeks. Let's go to 4 weeks. And just slowly kind of work out the amount of time. I'd like to share my screen again.
Sure.
Because Hold on, I got to jump up on
Wait,
my.
while you're sharing the screen, I'm going to just bring up a comment that Katie Bortel made. Silicon is smoother on the inside, and I actually have some slides. I don't have them ready of looking at a catheter cut open with an electron microscope, latex one. And when you see the surface on it, it looks really smooth to your eye, but when you look under a microscope, it's not. And that's what they think a lot of the adherence comes from.
Yeah, but the concept of the hydrogel is that it's supposed to create that water barrier, which is supposed to, it gets a little mushy, which is supposed to help with incrustation. And the silicone is slicker, and I do think that helps. But how much does it help compared to the fact that it's got a 45% larger internal lumen?
That too, yeah.
Okay.
It helps. It helps for me as a urologist in clearing clots, getting rid of debris inside the bladder. This is a cutaway view of a bunch of three-way catheters, and you look at the silicone on the very far left on top. It seems like the internal diameter is much bigger, even though the outer diameter is the same. And then I think the latex is the one third from the left, which is a smaller internal diameter. I mean, look at the size difference. That's incredible.
Yes, and that's going to help with clogging. So just to talk a little bit about changing frequency, is my slide up?
No,
not yet.
Okay,
there you go.
Is that a higher rate of infection is actually associated with frequent catheter changes, right? That makes sense because you're pushing something in the bladder, you can cause trauma, you can introduce bacteria. Every time you change a catheter, you're increasing the risk of urinary tract trauma, right? Because you're instrumenting through the urethra. And hydrogel catheters by manufacturer instructions are actually good up to 12 weeks. Okay, so if we're increasing the risk of infection, we're increasing the risk of trauma, and the catheters are good for up to 12 weeks, why do we change every 4 weeks? Do any of you know?
It's called dogma.
Exactly.
It's called status quo bias.
Yes, and it's also about money, believe it or not. The practice actually started because when Medicare under the periodic billing system created a rule where they could change catheters every 30 days, people started doing it every 30 days. Okay, so it's actually a billing thing. And when the billing people said, hey, we can get paid to change it every 30 days, they started changing it every 30 days. Okay, and it's not evidence-based at all. And me at the VA, we're changing them every 4 weeks, and we don't get paid through Medicare. Okay. So what is the best catheter changing frequency? For me, I think the catheters should be changed only when clinically necessary or per manufacturer's current recommendations. And that is actually if a doctor is going to have to write an order, that's the order I usually tell them to put in, not a regular changing frequency. And so what do? Usually when I get a patient, they start with every 4 weeks because that's what they usually come with me with, right? And so when I remove the catheter, I can cut it open, I can assess it, I can say, okay, we're going to do these things to improve. This catheter is looking pretty good. Why don't we go to 5 weeks, right? Then I'll change after 5 weeks. Or if I'm dealing with incrustation, I might be changing every week or 2 weeks, and I'm doing the same process. And as I make interventions, I'm increasing the length of time, and then I'm assessing, improving. Okay, let's try 6 weeks. Hey, let's try 7 weeks, and eventually I'll get to a goal where we need to reach. And so in my program right now, the average time that we're changing catheters is about every 8 weeks. And sometimes that's based on the nursing situation where the nurse is going out every 8 weeks. And so it's good for them to get it to that. We have some people that are a little quicker, and I have one patient that is actually going 12 weeks. This is actually him. He sent me an email with a picture of his catheter that said that he wanted to share a picture of the catheter he just removed. It looked so good, he was going to go to 12 weeks. And he was posting this picture of the catheter on a spinal cord site.
Interestingly, that's a silicone, and that's not a silicone catheter.
No, it's not. And he was having some problems with the silicone, and he had a latex for so long. And this guy has been catheterized for 25 years. And I really love silicone, and I try to move people to silicone, but there's just some people that aren't able to tolerate it for whatever reason. And he was having some spasms from the silicone.
It
And
speaks to the importance of custom tailoring the treatment and the choice of catheters to the specific patient.
that's absolutely true. And so it's kind of a trial and error technique, but you don't just assume that one catheter is going to be better than the other.
I think it was a great point that you made about the catheter, how frequently they're changed, because I'd read some of that same information and switched patients away from that 4 to 6 week dogma training that most people had, and just started pushing. Most of my patients were doing fine with 8 to 10 week catheter changes.
Mm-hmm.
And I think 12 week wouldn't be unusual. And they like it better because they don't want to come in the office any
Right.
more than, and I like it better because the last thing I need is 10 catheter changes on a normally busy schedule. So that's really,
I think I found out about that in like other countries. They would do them every 3 months. And
Yep.
when, here in the States,
Yeah.
we would tell people, oh, every 4 weeks, every month. And they get that in their head and they're like, oh no, I can't go 5 weeks. No, I have to have it now. No, it's okay.
No,
And it's hard to
and
get through to that.
it's a billing rule. We're doing
Yeah.
it because of billing, not
Yeah.
who'd ever
because
think
of-
money would have any influence on it? Right?
Yeah, right.
Hey, before
So-
we this is a great talk, Todd. I really enjoyed it. I think you've got a lot more to share with us. So I'd appreciate if we can try to book another date to continue this discussion, because really a lot of good things came in. I do have a few comments from the audience I'd like to bring out here. Katie Bortel answered a question to the ProScar issue. One of the reasons you don't crush it is because it can absorb some of the medication through the skin. There's a protected coating on the pill, and it can irritate the stomach lining and release too early. So I was
Since that
unaware of
question was initially asked, I actually did look it up. There is a film or coating around the finasteride tab, and it is recommended that you do not crush it or divide it. And the worry about systemic absorption is handling of the medication with bare skin by possibly a gravid female. And that medication can, if the baby's a male, then that medication can impact on the development of the baby.
Yeah. And now Leo Ligon said, by the way, wanted to let you know, much appreciate the Yellowstone shirt that you have. Didn't notice that, but cut it open, silicone chelating, increased fluids. That was the bottom line he took from it. But a question: chronic suprapubic tube patients, usually on polypharmacy, what oral medications may increase urine calcium?
So there's a lot of medications that can cause a little bit of problems, and it's not just urinary calcium. You can have plenty of calcium in your urine. It's the incrustation, okay, and that's the rising of the pH. But if you want to discuss with a pharmacist and ask them to do a pharmacy review, they're not going to know what you're talking about with incrustation, but they can do a review for stone formation, because essentially incrustation is the same process as an infected stone formation. And there are medications that can cause a little bit of problems with that. But I actually have a little bit of a presentation on that, but I know we're running out of time. But talk to your pharmacist and ask them for a stone formation if there's any medications.
Yeah, I was just going to say that the incrustation, it's the stone prevention diet, basically, with the lemon and the citric and whatever. So basically preventing a catheter from being encrustated is like a stone prevention diet.
Yeah, absolutely.
Yeah. It's just understanding what's happening with a urease producing bacteria and how it works and what to do about it. So
the big 3 takeaways are: number 1, consider changing your catheters up to 12 weeks. Number 2, silicone catheters are good or sometimes better and have a bigger inner diameter than a latex catheter. And number 3, citrate works well to decrease incrustation.
Thank you for that nice summarization, John.
Thanks.
All right, for all of you that have been attending here, if you want to continue the discussion, don't forget about the after party that will be open after this closes. Just click that button on the website. And don't forget, I did add the calendar so you can take a quick peek at what upcoming events are available. We're filling that calendar as quick as I can, so we're going to keep this thing going. Again, I would like to thank our panelist, Todd, for that great presentation, and invite you to come join us at the after party if you'd like. Otherwise, we'll look at trying to get you on for more catheter talk.
All right.
Great topic.
I'd be
Great
happy to
job,
come
Todd.
back.
Great. Thank you very much. We'll see everybody. Hopefully see some of you again over in the after party. Join us soon. Good morning. Enjoy the rest of your day.